Many articles being reported in the literature in which they looked into effect of the letrozole compared with clomiphene. And at present, we can say that there are very few studies which being conducted or reported regarding the effect of letrozole in ovulation induction and pregnancy, either alone or in comparison to clomiphene citrate. One of these articles being reported by the group of Casper in the year 2001, and what they found that dosage of 2.5 milligram per day of letrozole achieved about 75 and 100% ovulation in anovulatory and ovulatory patients respectively. Other studies also showed higher ovulation with letrozole. This may because they included all patients with PCOS, whereas in many others, they selected other patients with PCO who didn't respond to 100 milligrams for comparison. Information about the teragenic capacity of letrozole in humans is lacking. But in animal studies, it has been shown that low doses of letrozole are effective in inducing noxious effect on the development conceptus. In the rat, teratogenic effects including fetal domed head and cervical centrum vertebral fusion resulted from exposure to a dosage of 0.03 milligram per kilogram. In the rabbit, embryotoxic effects were induced by exposure to letrozole, and the daily maximum recommended human dose, according to this, is about 1 milligram 2 meter basis. Although the extrapolation of animal data to human is a complex and it's very tough to conclude, these findings suggest that letrozole might have the capacity to elicit teratogenesis in human embryos. Indeed, other study by Badawi, which looked into the clomiphene citrate or letrozole for ovulation induction in women with polycystic ovary syndrome, they conducted a prospective study, and what they found in their study that they shown that the advantage, they didn't show any advantage to the use of letrozole over clomiphene citrate as a first-line treatment for induction of ovulation in women with PCOS. This study was published in 2009. But again, in the era of evidence-based medicine, we should look into either prospective trials or either meta-analysis in order to conclude the right decision and make the right conclusion. This review was reported in the last year, in 2009, in which they looked into the aromatase inhibitors for female infertility, and they conducted a systematic review of the literature. And what they found in this review, that clomiphene citrate remains the first-line treatment choice for ovulation induction, since it's widely used, effective, and relatively safe regimen, according to these authors. Aromatase inhibitors, and mainly letrozole, offer a new treatment choice for infertile women, but the risk of teratogenicity, which is used by these with aromatase inhibitors, may reduce of its use. Recently, in May this year, the SOGC clinical practice guideline from Canada reported their recommendation upon ovulation induction in patients with PCOS. And what they recommended in the bottom line, that clomiphene citrate, according to these authors, has been proven as effective in ovulation induction for women with PCOS and should be considered the first-line therapy. Patients should be informed that there is an increased risk of multiple pregnancy with ovulation induction using clomiphene citrate. When it comes to gonadotropins, they wrote that gonadotropins should be considered as second-line therapy for fertility in anovulatory women with PCOS. The treatment, of course, requires ultrasound or laboratory monitoring, high cost, and the risk of multiple pregnancy and ovarian hyperstimulation syndrome are drawbacks of this regimen. They wrote that in 2005, the Health Canada and the manufacturing company of the letrozole issued a physician warning letter on the off-label use of letrozole for fertility and the possibility of embryotoxicity phytotoxicity, and teratogenicity. This followed preliminary research finding by Bijan et al. Comparing the congenital malformation in babies conceived with letrozole, with or without gonadotropins, with those in babies born to a low-risk population of women without known fertility treatments. These findings reported a higher incidence of both cardiac and bone abnormalities in letrozole group. However, Tulandi have evaluated about 910 cases of newborns from letrozole and clomiphene citrate pregnancies. The group of Tulandi found that 2.4% of incidence of congenital malformation and chromosomal abnormalities in the letrozole group versus 4.8% in the clomiphene citrate group. However, the recommendation by these authors that until aromatase inhibitors have been approved for ovulation induction by Health Canada, they should be used with caution in patients, and patients should be carefully consulted given potential medical legal implications. In our country, the off-label of letrozole, we don't use it anymore for ovulation induction except in rare cases of breast cancer or other application in which we have the ethical committee approval of the use of these medications. But if we summarize this data, we may conclude that still clomiphene is the first-line therapy coming after gonadotropins, and we may consider the use of letrozole in selected cases. However, if you look into the recent literature, and then a review published currently by Elizabeth Pritz, in Current Opinion Obstetrics and Gynecology, she summarized the old literature, and she came into the conclusion that in women undergoing ovulation induction, in the case of an anovulatory infertility, or women undergoing controlled ovarian stimulation, namely patients who are treated in IVF cycles, letrozole, in contrary to have been reported before, according to this author, is an excellent alternative to either clomiphene, citrate, or injectable gonadotropins. Furthermore, she wrote that it has minimal side effects, no proven teratogenicity when used for ovulation induction, and is more cost-effective than other available therapies. So if we summarize, nowadays, still the first line of therapy for anovulation, or if you want ovulation induction, we should use clomiphene citrate. The second line of therapy might be either gonadotropins or letrozole, and if you fail, of course, you go toward IVF. The use of letrozole, according to most of the meta-analysis, should be considered in some cases, and after the patient gave their informed consent to the option of teratogenicity among the babies.